Welcome to the Healthcare Innovation Podcast. My name is Dmitry Petrov. I'm an assistant professor of neurosurgery at the University of Pennsylvania. And our first guest is Krzysztof Wodanski. Krzysztof is an assistant professor of anesthesia and critical care at the University of Pennsylvania. He's also a senior fellow at the Leonard Davis Institute for Healthcare Economics. Krzysztof, thank you so much for joining us. I know that you're on service currently and busy taking care of many very sick patients. So thank you and welcome. And what we're going to be discussing today is how do we maintain a high level of critical care in these trying times. So to begin with, how are you? How are things at the hospital? How are things on service? What are you seeing currently?
So things are busy. We're actively preparing for the search of the patients. We're looking at the example from the other countries, China, Italy, actually European Union. We expect significant uptake. We're a little bit puzzled how much patient we will accept, but we're planning for the massive search, and we actually assume that this may overwhelm the hospital one way or the other. Otherwise, everybody works very diligently. It's, again, a little bit race against the time.
Understood. And so aside from the shortages in equipment that everybody's been talking about, what hasn't really been mentioned so far is what we will do once we start running out of critical care doctors. As doctors get infected, become quarantined, what is the plan to maintain our level of critical care as this progresses? Because it seems as though it's not going to be a sprint, it's going to be more of a marathon. So what would you say to that?
So it's probably going to be a half marathon, and we're actually really concerned about staff as a primary bottleneck once the people start peeling off. There's not much we can do in terms of the nurses except to protect them as best as we can, because, again, manual labor or this manual contact with the patient is something that they have to do. But we're very concerned about our intensive care physicians. Significant number of the COVID patients requiring ICU care. So the question is how you multiply this, how you actually do a match between the demand and the supply. We know that we run of our physicians. We already running pretty tight schedule. So one of the things that we believe is the best utilization, we have a very innovative thinking about using the telemedicine as our force multiplier, how we can utilize these fewer doctors and keep them safe, the doctors who are trained in critical care medicine, and use their skills by the hands or by the minds of the people who are actually not so familiar with the critical care medicine. So what we're talking here is about the multiplication of the force in effect.
Right, so that's a military term describing how one person can, affect a much greater force than you would expect. In this setting. So just for our viewers, just explain what you mean by telemedicine in this setting.
So telemedicine actually arrived many years ago, but the telemedicine in general means is the way to examine or provide a healthcare to the patient using remote access. So I never touch the patient in that case. I use the cameras, audio, some people use the robots. There's a lot of way to interact with the patients using a subsidiary, so to speak. I can also direct the care of my patients using the computer, electronic record system. So everything's on my fingertips except the patient itself. So this is the telemedicine. And the telemedicine very slowly started developing in the United States, mostly because of the lack of the billing, most of the very complicated regulation, but we see a lot of that disappears. Telemedicine allows me, for example, go to the rural Minnesota and be a doctor over there as an intensive care doctor, even if I'm sitting in Hawaii and sitting on the beach over there. I can sit in Philadelphia and treat somebody in Antarctica in the station over there. So this gives you a lot of options. But the force multiplier is different. Force multipliers is that I make myself available on the very short notice or the immediate notice to the people who do not practice telemedicine. That's a very new and innovative concept.
So in practical terms, at some point I expect that I myself as a neurosurgeon, while I have a good amount of critical care experience, I'm obviously not an intensivist. And so as my turn comes up, as staffing becomes scarce, and as I'm taking care of patients in the intensive care unit, you will be in a command center far away
Mhm.
and everything in the room will be visible to you. You'll have audio, you'll have a camera, you'll see all the vital signs, you'll see all the lab readings, you'll see everything in real time.
Mhm.
And you can direct myself
Mhm.
and a nurse
Mhm.
as skeleton staff on the ground to actually provide the kind of care that you would if you were right there at the bedside.
That's absolutely correct. So what I do the expertise. In current medicine, a lot of people have some basic understanding what to do with the patients. You, as a
Mhm.
neurosurgeon, know that there are, physician extenders like APP, PA. There are fellows who are not licensed to work independently, but they do know a lot of medicine. There are residents, there are nurse anesthetists. All those people have a medical knowledge which is enough to provide a basic care of the patients. What I need to do, I need to put the layer of the critical care on the top of that. And the benefit is that I just provide this crucial component, and now I have 10, 20 people working with me, and I don't need to attend to all these minute details of the other patient's condition, which is very, very standardized. So if you combine telemedicine with my expertise and the standardization, suddenly I can care for more, I can be a consultant or the guiding physician for 10 for the 10 patient, for the 10 people between me and the patients, and those people can take care for another 10 patient needs. So suddenly I have 100 patients under my care,
Right,
instead of me being only take care for the 12 of this old way when I do the rounding. So this is the multiplication. This is the multiplication.
right. And it also protects you as the intensive care doctors from potentially becoming infected and having to be quarantined. And frankly, if you're able to do this from home, potentially, then you can even do it in quarantine at home. And so it seems in this kind of environment where we're likely to start running out of not only manpower, but also somewhat out of brain power, right? Because intensive care docs are in the front lines, and you will be the first to get infected along with the nursing staff as these things pick up. And so it seems like it's a very innovative way to tackle something specifically like this. And you have to sort of um, applaud Penn Medicine for having this in place. And it seems to be the perfect sort of setup to ensure that we can get out ahead of this, I would say.
Definitely. So this is, in Penn Medicine, the telemedicine program was active in the forefront for several years. What you can say now, this crisis forced us to think very, very out of the box. And, this is a huge paradigm shift. The doctors are usually on the front line. So with a brute force, which will take, with a person who will take a brute force, moving us as a critical care front physician to the back and making sure that we can provide as critical expertise while relying on the knowledge and skills of the people who don't have a critical care is very, 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 very new. And Penn Medicine make a lot of strives to make this happen. It's not easy process, obviously. We have to have a lot of protocols, a lot of very clear line of communication. There's a lot of trust. There's a lot of reliance on both sides. I can't work without people on the ground. They cannot function without me. So this is mutual beneficial relationship. And having a leadership who decided to put this in place is absolutely breakthrough. The only thing that that kind of help us over here is to get this couple extra months, because we see what's happening in China and the people are already thinking, how can we avoid that disaster situation when the system is overwhelmed.
I see. And so just to reiterate, you mentioned that you have to have the technology on one end. You also have to have the protocols, very strict protocols on how we're planning on treating these patients. And what I've seen circulating around the health system is that those are being put in place, that it's becoming very protocolized. And it seems to be that, if we reach a certain bottleneck, then this will be in place. And so question is, well, what is that bottleneck? When will we go to tele ICU almost completely? Has that been discussed? Is there a point at which we'll switch over, or is that still a sort of a moving target?
So our sort of protocol involved three models. The first consultative model, which is the old model, we're not going to apply. The other one is the force multiplier model. which we just discussed. And the third one is that we becoming pretty much a primary care providers, using people who are not considered close even to critical care. We're talking about maybe dermatologists being a doctor, maybe a resident in the initial stage being a doctor. That's much more involving. A lot of depends how many patients we get and how much we can actually process in our system. But that is why we also want to have a protocols, because the protocols allows for delivering the best practices with the minimal variation. But the very important part of that is that the time I spent on the patient is only to the things that needs to be attended. So to speak, a creative thinking is eliminated, which is, I believe, the variation in that case. So the resident or whoever's on the ground knows what's expected to him. If you run into the trouble, I camera in, I provide the support, and we just move to another patient. So my time with the patient is, on episode is maybe 5-6 minutes, instead of having 20 to 30 minutes conversation. Now I can do several patients, 12 per hour. So that's significant relief of the any bottlenecks. And the other thing is, we can scale this up very, very easily, because as you say, we can take the physician from the home. We can have somebody who was sick and now is recovering. We can just give them computer, connect them to the system. And suddenly, our system goes from 100 patients, because I'm the only one, to 200, 300, 400, and so on and so forth. Infrastructure exists and the person, so it's extremely flex system.
Fascinating. I want to thank you. I'm not going to waste any more of your time. I know that you're on service currently. Thank you for that information. I think that's valuable for our viewers to understand how we are in our health system are forward-looking and trying to solve this problem before it gets here, and hopefully this will be helpful to people. Thanks again. Any closing remarks?
No, I just hope that everybody would stay home and give us as little work as we can. That would be great, and please stay safe. Thank you very much for this opportunity.
Thank you, Christoph.